Oh, okay. And videos.
Pardon?
Video. You can open your video.
But the videos are open now.
No, your video, your face.
Where is that?
Again, double click. Yes, try to go here in the blue dot. Yes. Move my video.
Start video?
Yes. That video. Now this is okay. Now I want to see your face.
So, yeah, look.
Yes, I can see. Try again here. No, in the dot, in the blue dot. My audio. I don't know why I cannot see. Again, now.
What I can do is I can hit escape and let me get out of this. Escape and video. It's not there. It should come up, but oh, here we go. Video. Here we go.
Nice, yeah.
Okay.
But it's not moving.
Okay.
Why is not looking?
I don't know why.
Click here. Yes. Yes. What do you say? No. His face done. Select the camera, but this is the camera. Okay, you can speak and we'll see there.
All right.
You cannot see your phone. You can start again.
Okay.
There was a.
I don't know why it's not working. Chat share video. Choose an avatar.
Yes, let's see the. You have the option for the video.
Yeah, it's not coming out, you know. I don't know why, and it should be the video up here. And
Video background is still loading. Okay, don't use. I don't know why it's not.
All right, so just leave it without video.
Okay, but we can start, no problem.
Okay.
Go with the first then. Oh. You can
So,
start again. Yes.
Good morning, and it's great to be here. Eventually, to meet you in person at Taumina, the hospital that I've had so much association with over the last 3 or 4 years with Sasha, and to meet him finally. So we're going to talk about AV septal defects, particularly the correlations between what you can see on ultrasound and what you can recognize on morphology from each one of these specimens. So each example will have a pathological specimen. I've done these in connection with Bob Anderson, over 30 years of work with him, and Diane Spicer, and from my own collection at the University of California in San Francisco, where I was about co-curator of the Autopsy Museum. So I put together this volume, and this is part of chapter 3 from my new book on echomorphological correlations in congenital heart disease, which is published by Springer.com. So I can't get this out of the way.
Go to the menu.
Okay.
Yeah, closes. Oh.
Okay. So we always begin our talks with embryology. This is from the embryonic mouse at 10.5 days E, courtesy of Professor Robert Anderson, and this is available on the website for the Congenital Heart Academy. from one of Bob Anderson's or from one of his many lectures. And this is a mouse, a fetus, at halfway through gestation. And you can see in this heart that the heart is already looped with a D loop, and that this is the AV canal here, which is draining exclusively into the morphologically left ventricle. The ventricular septum has started to form. This is the primitive right ventricle, and this is the outflow tract, the conus and the truncus. We're looking at the conus with the two cushions developing in the conus, of which the division will make one the aorta on this side and one the pulmonary artery on the other side. And this aorta is going to have to spiral in a fraction session and come to lie in the left ventricular outflow tract, which is going to migrate across the AV primary atrial septal, ventricular septal area, and provide inflow into the right ventricle through what will become the tricuspid valve and the mitral valve. So this is the embryology, which I think is very important because we see this all the time. This is the superior endocardial cushion, and this is the inferior endocardial cushion over here. And here we can see in a little later stage that the atrial septum has started to form. This is the dorsal mesenchymal cap, and over here is the spine of His, the ventricular spine of His, which go together and will separate this canal, which, as you can see, has started to move over, and a small portion of it has already started to migrate over the right ventricle. And this is still a common AV valve. And when we look at the normal heart, I'm going to just put this in close there like that. We see in the heart cut in the same projection as you see here down below. Let me just move this out of the way. Okay. That this is the right ventricle with the tricuspid valve here, the septal, anterosuperior, and inferior mural leaflets. And this is a drawing from Dr. Frank Netter's book, which was published in 1955. And you see how beautifully he looks at the pathology. It's exactly the same picture, except he's now colored all of these things. So these are the lateral cushions. This is the superior endocardial cushion, and this is the inferior endocardial cushion. Here's the spongy nature of the left ventricle, the primitive right ventricle, and those two spirals that we saw here. And on the right, we have an AV canal with pathological imaging seen from the right ventricular apex area. And you can see here again the components of the ventricular septum with a big defect, and lying over that, a common atrioventricular valve orifice. The abbreviations are, as you see here, AV valve orifice. And here's the aorta, which is not separated like they have here. And in the bottom is an echocardiogram taken in the subcostal oblique view and showing almost identical features to what is seen in the atrioventricular septum. And in fact, you can see very beautifully here the lateral leaflet with the two papillary muscles in the left ventricle, the superior bridging leaflet attached to the septum, so this is a Rastelli type A, and the tricuspid valve and Lagen, the inferior bridging leaflet attached to the ventricular septum, and the inferior leaflet attached to the papillary muscles. So that's really the essence of what we see here. And the concept by Echo is that there is either a AV canal, which we've represented diagrammatically here, and here the valve leaflets have attached to the ventricular septum, leaving an interatrial communication. Occasionally, the valve leaflets attach to the underside of the ventricle and leave a ventricular septal defect with only ventricular shunts. And here are some pathological examples we'll get to in a moment. And this is the type associated with common AV canal defect, where there's both an atrial and a ventricular component and an AV valve floating between the two. And so here you have an ostium primum ASD, no ventricular septum. Here the ostium primum ASD has been obliterated, and the tricuspid valve is seen with the AV valves below it. It's actually not a tricuspid valve, it's an AV valve. And lastly, we see a secundum, a primum atrial septal defect, a complete AV canal with leaflets straddling across the ventricular septum, as you see it here. And this is, again, a Rastelli type C lesion because the superior bridging leaflet defines everything. Please, if you have any questions, just raise your hands and I'll try and attend to your answers. So this sets up a whole series of fundamentals about the morphology of an AV canal. On the left is a normal heart, and you see the length of the inlet septum here to the central fibrous body in the mitral and tricuspid valves is fairly long distance. Here's the tricuspid, here's the mitral with a little offsetting. There's the inferior cava right here, and this is the area of the oval fossa. And on the right is an AV canal cut in exactly the same defect as this is here. And here you can see that the inlet septum is much, much shorter. So this has not had an opportunity to grow. And the AV valve, instead of being two, has one leaflet crossing across the defect with always uniformal caudal attachment to the crest of the ventricular septal defect. That's what Rastelli said when he saw it. He said that the inferior leaflet does not help you classify the defects because they are always uniform with attachments to the underlying ventricular septum. And we know that this defect extends to the crux of the heart. And that's important for the surgeons, as they know, because they have to put a patch in here. Otherwise, they leave residual VSD. And here is the ostium primum defect here. So this lesion is not an ASD and a VSD, but it's a common lesion. And also the fossa ovalis is a patent. Here you can see the primitive septum primum on this side and the remnant of the rim of the septum on the right atrial surface. So you see the difference between a normal heart and an AV septal, that there is in AV septal defects a disproportion in the length of the septum between the inlet and the outlet. There is a common AV junction, uniform, regardless of whether you're dealing with an ostium primum ASD or you're dealing with a complete AV canal. And there's a common AV junction always in this condition. It's not two AV junctions as you see them here in the normal heart. So those are some of the common features of an AV canal. And of course, on echo, you can see that very beautifully. This is a posterior leaflet. We know that it's the posterior leaflet because we scan from the crux of the heart, showing the coronary sinus and move forward a bit. And that first leaflet that you see is the inferior bridging leaflet. And there's the tendinous cords attached to the crest of the septum. If we look at this from short axis, we can look at this from above and we can classify all the lesions here. This is superior and inferior bridging leaflet. This is the septum. This is the mural leaflet of the left AV valve, because we're looking from above downwards, as a surgeon would do. And this is the tricuspid valve with anterior, superior, and inferior leaflets. And on the right is an echocardiogram taken in the subcostal cut, which shows the same things, but in a mirror image presentation. So let's just look at that. Here you see, again, another feature of AV canals is that the aorta is not situated in between the AV valves, but has never had an opportunity to come down because the AV junction has remained as a single structure. This is the posterior bridging leaflet. Here's the anterior bridging leaflet, and here's the bare septum of a complete AV canal. And of course, we're looking at this back to front. So here's the right ventricle here. This is anterior, superior, inferior leaflet, inferior bridging leaflet, bare septum, superior bridging leaflet, and mitral valve. And I'll take that away for you. And there's the valve leaflet which is attached to the crest of the septum, the superior leaflet. So this must be a Rastelli type A AV septal defect, easy to recognize. And here's the inferior bridging leaflet. Here's the mural leaflet. This is very important because they're papillary muscles here. And the position of the papillary muscles is essentially very important in terms of functionality of the left AV valve. The closer they are together, the more the chances of AV valve regurgitation that cannot be fixed by just simply sewing the cleft together. So this is something that we tell the surgeons when we see it, and the papillary muscles are widely spaced apart here, giving rise to a good mural leaflet over here. And that at least lets the surgeon sleep a little bit better the night before he does or she does the surgery, because there are female surgeons that do wonderful work. Okay, and here you see the valve leaflet moving, opening and closing, and you can really see the entire aspect of the AV valve with this thing. You see, we're seeing the right ventricular outflow tract here. The right ventricular outflow tract is anterior, so the probe has to be rotated round in a halfway to get this picture and show the whole AV valve. And we can tell the surgeon everything that he needs to know about the morphology of the valve from this image. And of course, this is handsome guy, is another Italian called Giancarlo Rastelli. Okay, this will be online. You don't have to take these pictures, but if you want to, you're welcome to do that. So this is Giancarlo, who worked at the Mayo Clinic and looked at different canals. This is the kind of AV canal which is attached to the crest of the septum there. So this is type A. And if this valve extends over further without attaching to the crest of the septum, we have a Rastelli type C defect. And here you can see papillary muscle, anterior superior leaflet of the AV canal, and the septum without attachment to it. So this is a Rastelli type A. The other thing is that papillary muscles support the commissures. So if you have an isolated cleft in the mitral valve, the papillary muscles are often widely spaced, and the cleft can vary in its position all the way around here. In an AV canal, the papillary muscles are closer together. They're rotated round, particularly the posterior inferior papillary muscle, and they get closer and closer together, and eventually they can fuse and give rise to a parachute left AV valve. So finding these papillary muscles is quintessentially important. In the normal heart, most of the circumference of the valve is made up of the parietal leaflet. In an AV septal defect, most of the leaflet is made up of the anterior bridging leaflet, and the inferior leaflet is much less. So here's a picture of the papillary muscles in a isolated cleft. You can see the cleft between the two anterior superior leaflets and the papillary muscles in normal position. And here they are rotated round a bit there. And as Dr. Alain Carpentier said from across the border in France, the left AV valve in an AV canal is a tricuspid valve. Look, anterior superior leaflet, inferior bridging leaflet, and the mural leaflet. So the leaflet is a tricuspid valve. It's never been a mitral valve, and it never will be a mitral valve. So that's a bit about the muscle and also the echocardiographic thing. Now, we said that there's a disproportion between the anterior superior bridging leaflet and the inferior bridging leaflet. And in fact, the septum is abnormal. In the normal heart, the ratio of the outlet to the inlet is 1:1. In an AV canal, because the inlet septum doesn't grow, the ratio is greater than 1:1. Okay, and that gives rise to the gooseneck deformity, which was described by Murray Barron in 1964. And so what I've done is I've drawn on an echocardiogram a gooseneck for you. So there's the goose's eye and beak, and here's the neck of the goose, and this is the part that makes the neck here. And below here is an angiogram, which shows you this gooseneck deformity. It's an angiogram that I did when I was in the cath lab. So there you go. You see the red dots. that's where the septum is. It's not related to effusion of the leaflets, but it's actually an abnormality related to the fact that the aortic valve does not come down and settle into the left ventricle, but that distance remains, and that causes this elongation and causes the gooseneck deformity. And here's an angiogram showing the gooseneck again. And I'll take this away for you in a minute. Let me just move this over here. Okay, and there you see the gooseneck very beautifully. I can also try and stop the goose. It won't let me stop the goose because I'll push this over there. Oh, it won't let me stop it. Okay, so here again is another example of the gooseneck showing you that the gooseneck is not related to fusion. In fact, if I ask you, what is this lesion? Was this a complete AV canal or was this an ostium primum ASD? And you have to give me an answer. Well, I don't hear any answer, so I'll give you the answer. This was really an ostium primum ASD. All the valve leaflet tissue was removed and shows this inlet-outlet disproportion over here. That's related to the functional structure of the fact that the aortic root doesn't come down and really get into the left ventricular outflow tract. And that's also important because it narrows the left ventricular outflow tract. And the left ventricular outflow tract can also be subject to lots of problems in AV canal defect. Here's the normal heart, and here's the gooseneck deformity. Here's another heart that does the same thing. Now we'll look at the left AV valve. And here again, as Carpentier has said, are the superior and inferior leaflets and the mural leaflet. The leaflets have fused together, making two AV valve orifices, a right AV valve orifice here and a left AV valve orifice here. Now I've switched this echocardiogram round so that it looks exactly like you're looking at it from here, because actually a slice can be turned in either direction. So we're looking at the AV valve here. There's the cleft in the so-called mitral valve there. Okay. And there's the attachment of the tendinous cords to the crest of the ventricular septum. I'll take that away and you can see that. And now I'll turn it around like a normal echo is looked at. That's the same picture looked at from the echocardiographic view, showing the cleft in the valve, the tricuspid nature of the left AV valve, and the very nice inferior bridging leaflet or mural leaflet there. I beg your pardon. That's the mural leaflet. There's the inferior bridging leaflet. So what about the atrial component? Well, this is very interesting because people call this an ostium primum atrial septal defect. That's standard bad terms that we use to describe this defect. But if you look here, there's nothing abnormal about the atrial septum. There's the oval fossa, there's the lower rim, and here's the bridging leaflets which are fused. And the embryology is that the bridging leaflets have not made contact with the atrioventricular valves. But the atrial septum is perfectly normal. There's the coronary sinus, okay? And the only thing that's happened here is this inferior bridging leaflet has not made contact. So it's an interatrial communication, of course. We won't argue that point, but it's not an atrial septal defect because the atrial septum is not defective. Many times, AV canal defects have defective atrial septums. And of course, this is pretty easy to recognize on a 4-chamber echo. There's the 4-chamber echo with color flow showing fusion of the two leaflets, the mitral and tricuspid, or the left and the right AV valve regurg, into one jet going from the left ventricle into the right atrium, and explaining that this is related to a entrainment of blood that comes across the atrial septum here, and the fact that the jets under Coanda phenomenon tend to fuse together. Okay, so that's that. And of course, here is an example of that cleft as you see it. This is given to me by Dr. Lily Lim and shows the cleft in the valve as seen by echo, 3D echo. And you see very beautifully here the superior and inferior bridging leaflet, the mural leaflet with the cleft going towards the ventricular septum. And also, if you do full volume and are able to do this in children, you can actually see where the leaflet is defective and leaking. And we can see the leaflet leaking in between the clefts, so that this is going to have a good chance of being well repaired when the cleft is sutured. Okay. The people that gave me this picture, Dr. Lily Lin from Edmonton in Alberta, Canada, says that their surgeons rely heavily on 3D echo evaluations to make this defect, not only to evaluate the canal here in this way in 3 dimensions, but also to look at post-operative deficiencies that can be repaired well. So I don't know why this one is coming up here. It shows a small mural leaflet on this side. There's the inferior bridging leaflet, superior bridging leaflet, and a small mural leaflet. That's going to be a problem. And clefts or deep scallops, now they'll get both in the left and the right AV valves, in the anterior and superior and inferior bridging leaflets. Now, ostium primum ASDs, here you see the atrial component very nicely. And the AV valve regurgitation that's occurring here is occurring not in the medial aspect where a cleft usually is situated, but between the mural and the inferior leaflets, and it's jetting exactly into the right atrium. There's no entrainment of this defect. And also there's tricuspid regurgitation as well. Now we can see how the defect actually embryologically develops from the specimen, because here's the inferior bridging leaflet, here's the ostium primum component, there's the left component, there's the right component, and they've been separated. And what's happened is this inferior leaflet has grown forward and fused with the superior bridging leaflet. I'm sure the surgeons see that all the time. Now, I put this picture in to show you the ASD here, but also to see that there's often other problems. And this patient has a partial core atriatum here, and you can see the acceleration of flow is occurring at the point of the core atriatum and then going through the atrial defect and into the right atrium. So you have to look at all things when you look at these cardiac defects. Here's a partial AV septal defect with a ostium primum component, fused AV valve leaflets, and a ventricular component. They call this a partial or incomplete defect. Okay, I don't like the term particularly. And here you see the interventricular component and the atrial component very easily on echocardiogram. So I think echo provided us with a lot of information, and especially useful in a preoperative evaluation together with transesophageal echo. So here's another example of what happens when this posterior or inferior bridging leaflet grows forward and fuses with the anterior superior leaflet. And that can bulge out and become aneurysmal. And this is such an example described in 1984 by the Japanese group as a tricuspid pouch lesion. And really what it is that there is an interventricular communication here. And it billows out this area that's been fused with tendinous cords coming over here. And it looks much like a membranous septal aneurysm. But when you see that, there's almost invariably a ventricular component. So you can tell the surgeon when you see that there's a ventricular component. Now, Mr. Rastelli described the anterior superior leaflet as attached to the crest of the septum. This is the normal inferior leaflet. Here's the anterior superior leaflet, attached to the crest of the septum. And here is a four-chamber view showing that there is the superior bridging leaflet, and you see it's attached to the tendinous cords there. How do we know it's the superior leaflet? Because we see the aorta here, we scan backwards, and the first leaflet we see is attached here, and then we get to the back leaflet, which is also attached. So we can recognize this, but it requires you to do a scan in a certain direction from the aortic root down to the anterior leaflet. I think it's easy. It's easy for echocardiographers to understand. It may not be easy for surgeons to understand. This is a rare example of type B interruption, where this papillary muscle is attached to the crest of the septum and has tendinous cords attached, but is not attached to the underlying myocardium in the anterior area. And I've only got one example in my own collection that shows this. Here is the big papillary muscle, and there is the ventricular septum next to it. And so this lesion is coming out and attaching, here's the papillary muscle, there's septum, is attaching across the ventricular septum. It's not attached to it, but is attached to a papillary muscle arising close to and adjacent to the ventricular septum, as you see it here. This is the classical example of a type C AV septal defect of Rastelli. This is a picture from Dr. Diane Spicer, which is available also on the Congenital Heart Academy. So excuse there's the back leaflet, which of course is attached. We've seen this picture before. But when we look at the front half of the pattern, this is the left atrial appendage, and this is the right atrial appendage. And this is the anterior superior bridging leaflet going from the right ventricle into the left ventricle. And here you see the ventricular septum, and there's the AV valve. It is not attached at all. So this is a free-floating type C Rastelli, and that's easy to recognize because when you see a leaflet that's not attached, as you see it here on this example, there's no attachment of the tendinous cords. The tendinous cords are running across from ventricle to ventricle. So this is a Rastelli type C. And that's easy for me on the four-chamber view. It should be easy for you, but it's much easier if you go in the subcostal locus. We've seen this picture before. Here are the two closely spaced papillary muscles. There's the anterior bridging leaflet. It's attached to the crest of the septum. And you've seen this picture before, so I'm going to move on. And I'm just going to show you this on the echo, which we've seen before too. And here's the anterior superior bridging leaflet attached, the widely spaced papillary muscles, the attachment to the posterior AV valve. So a subcostal view with the obliquity going out into the pulmonary trunk allows you perfect evaluation. And you can also do color flow in this area. And if you do color flow and you come down and up, you can see the origin of where the leak is coming. So this is very valuable view for looking at this, and certainly part of standard evaluation now. Here's another example of a type C Rastelli. How do I know it's Rastelli? Because this is a conoventricular defect, like a tetralogy, double outlet, transposition, truncus. Okay, when you get those things and you get an AV canal, Dr. Hanley told me it's almost always a type C of the AV canal. So we don't have to worry about it when we see this. The surgeons already know. Many things we tell the surgeons, they already know anyway. But the nice thing about telling a surgeon something that he knows is that he begins to trust you that you also know. And the important thing about echocardiographers and surgeons is they have to be bedfellows. They have to learn to trust, love each other, and know what the strengths of each particular specialty is in recognizing that defect. And that's a personality thing. That's not a science thing. So here you see there's the overriding aorta, and here's the anterior superior bridging leaflet there, which is so important in terms of, and you can see that it's not attached. So that's a tetralogy type We'll see more of them, so don't worry. So where we got to? We've got everywhere with 2D echo, except looking at the AV valves, which again, 3D is going to give to you. And I'm sure you do 3D echo here. And then how big is the VSD? Well, we see the VSD, they don't look so big. Sometimes they look very big, but they can look small and be big. And the reason they can do that is because the defect is kind of shaped like a half a moon. Okay. And the surgeons know that because they often measure the size of how big the patch is going to be. Okay. And I think that the important thing about being an echocardiographer with surgeons is that you get to go to the operating room and see what the surgeons are doing. Because in most curricula vitae of medical schools, there is no place for echocardiographers and cardiac residents to spend time in the operating room. And so a lot of pediatric cardiologists' idea of surgery is from diagrams rather than from actually seeing things. Okay. So here is, we're looking at the heart from the left side. So if you look at my heart from the left side, my anterior chest wall is forking this way and my spine is there. So chest wall is here and my spine is there. If you're looking at the right ventricle, the anterior chest wall is there and the spine is there. So this is anterior chest wall and this is spine. And what we're looking at here, here's the atrial septal defect. Here's the ventricular septal defect. Okay. Here's the superior bridging leaflet. There's the inferior bridging leaflet. You can't tell the Rastelli type over here, but you can certainly see the tendinous cords coming down. But this is the important thing, is the defect goes from there to there. And if you look at it from the right side, the defect goes from there, the back, to the front there. So you can see that this area, the A and B of the VSD, is completely different, that B dominates over A. And that's what we need to know. And we don't have to worry because the surgeons make the measurements. But here you see an ostium secundum defect, an ostium primum defect, and here's the complete AV septal defect going from the back to the front of the heart. Now, I mentioned this is tetralogy. Again, this is a Diane Spicer picture obtained fresh from a fetus that had died with tetralogy. I think it was a termination of pregnancy. So here's the pulmonary artery, here's the aorta, and when we look at the outlet, there's the deviated outlet septum, so typical of tetralogy, narrowing the right ventricular outflow tract. But if you look at the inlet, that's all AV canal, because here comes the anterior superior bridging leaflet across the VSD and attaching to valve in the right ventricle. And of course, this valve is free. We know that because it's a tetralogy. And there's the inferior bridging leaflet. So we divide this into two sections. The first section we look at, we see the AV septal defect, we see the deviated outlet septum, we see the VSD, and we see the right ventricle. And then on this example here, we see the short axis that we see here, and we see the valve straddling across the defect and attaching in the right ventricle. I'm going to take the labels off so that you can see that leaflet there straddling and attaching to a papillary muscle there. But it occurs as we move slowly and backwards and forwards. You only see it on a few frames. And I tried to stop this before and was unable to stop it. Let's see if I can do it today. Yes. Okay, I'm lucky. Okay, we're going to look at this valve. See, there it's going from there across the ventricular septum, which you can't see, and laying it in the right ventricle. There it's gone. Now it's divided and attached. You can't see that. But if you come backwards, there's the valve leaflet going into the right ventricle. I'll let it play for you, and I'll expand it so that you can get to see it in greater detail. But clearly that valve is going across. If you're an echocardiographer and you can't see that, I would recommend you go and do electrophysiology, because you're not going to make it as an echocardiographer. Okay, so this is just the isolated ventricular component. And when you see an isolated ventricular component, you will find that the mitral or the left AV valve is cleft. And when you have a cleft valve, you have caudal attachment to the crest of the septum. So here's the tricuspid valve, recognizing that this is a perimembranous defect. And here is the caudal tendony attached to the crest of the septum, because when it hasn't yet formed, it's a forme frust, as they say in Italian, in French, of an AV canal defect. So there's still the caudal attachments. And the surgeon needs to know that, because if you tell him it's a perimembranous VSD, it becomes very hard to fix the mitral valve through the VSD. You want to open the ASD. So tell the surgeon that, you make a friend of him for life, and he gets to believe you. And in case you didn't believe that this is a tricuspid left AV valve, here's a short axis view of that valve. And here you see the tendinous cord. And if you follow the tendinous cord, it always goes to the ventricular septum. Okay. All right. And then I've got more pictures of that. I'm going to run through them because I think it's very beautiful that you can see the cleft here of the left component of the valve coming through and attaching to the crest of the septum. This is the other problem of the left ventricular outflow tract. We described the inlet-outlet disproportion. And this is a patient with inlet-outlet disproportion, but because the left ventricular tract, outflow tract, doesn't get a chance to develop, the gooseneck is very narrow. And so there's the potential for left ventricular outflow tract obstruction there that you have to tell the surgeon about. Okay, so here's an example of a patient that we recognized in utero that has got a valve which is attached to the crest of the septum, maybe obstructing some of the outflow tract, a subaortic membrane, which you can see there, and an aortic valve. So there are three things in the left ventricular outflow tract, and you see the narrowing here. See that? There's the subaortic membrane, also attached to the anterior leaflet. Okay. Okay, so tri-level obstruction here. This patient had to undergo a Norwood procedure because we couldn't open the left ventricular outflow tract. We recognized this in utero. This is the postnatal echo. Here's an example of subaortic stenosis in AV canal from a paper I wrote in 1991, showing the superior bridging leaflet straddling across the VSD into the other ventricle. There's the subaortic membranous stenosis, and here's the aortic valve just above it. And here's another example of the same thing in MAG, showing the valve leaflet, the subaortic obstruction, the narrowing, and the aortic valve. And you can see the way the aortic valve is moving like that there must be obstruction related to the subaortic stenosis. You don't do M mode anymore. Now, here's an accessory orifice of the mitral valve. Here's the first orifice here. There's the AV canal defect, caudal attachment to the crest of the septum. And look here, in the inside, underneath the aortic valve, is a separate little billowing membrane. Okay? And I think it looks nice here, but if you really want to see what it looks like physiologically, look at the echocardiogram. Here's this little membrane there. There's the other main orifice of the left AV valve. And you can see this is attached here. These are actually quite easy to remove surgically. The way we've done it is it's very hard to hold it, put in a suture in it, pull it through the aortic valve and go, that's it. Even a first-year resident can do that. You can. Really? Okay. If you ever get to see that as a first-year resident, you'll be lucky. Here's another example of dual AV valve orifice. One, and the main orifice here. This one, you probably close this and try and make some plastic procedure here. Here you see the secondary orifice here going backwards and forwards, and the primary orifice is big here. The thing about looking for the secondary orifices as echocardiographers, we like to look for orifices down close to the chordae tendineae. The orifices are mainly annular in their position. So you have to look up at the annulus to find the valve. And if you don't do that echocardiographically, you're going to miss that. It's going backwards, which is not what I wanted to do. Sorry to folks. Okay. So we've seen that. And so, of course, the wonderful thing that you can do is with 3D echo, you just get a full volume. And I need to close this down. Can't get rid of it. It doesn't matter. We're at the end here. So here you can see a dual orifice here. And here's one where the main orifice is good and the mitral orifice is extremely small. Okay? So here's the parachute valve. And this is a AV canal where the left orifice is small. This is, again, another example of the 3D echo that you can see here, showing a single papillary muscle. You see, there's only a superior bridging leaflet, an inferior bridging leaflet, and hardly anything left between the two. Here's the superior and inferior bridging leaflets. Here on echo, you can see the solitary papillary muscle receiving all of tendinous cords. And in this one here, you can see the AV valve here. There's the solitary papillary muscle. And here is the tendinous cord attached to the superior bridging and inferior bridging leaflet without a mural leaflet. And lastly, the dominating left ventricle. Here's a right dominant AV septal defect. With a patient like this in a small left ventricle, you're looking at a one ventricle repair. If you have the right, you already got the same thing. It's almost like tricuspid atresia. There's a small right component with a small right ventricle. You can maybe do a 1.5 ventricle and get to grow the patient, but it's not a slam dunk. You can't do that on those patients that I've just shown you. And that, of course, has got to be a consultation between the surgeon and the echocardiographer, or with the MRI and CT team as well. Okay, I'm going to skip through this, but here's again is a post-operative example where there's been a cleft in the valve and the cleft is still not completely done. So the patient went back and got the cleft done. Okay. And this is afterwards. So in summary, common AV junction, a sprung aortic root, inlet-outlet septal disproportion, narrowed left ventricular outflow tract, swivel of the papillary muscle, and smaller than normal left mural leaflets of the aortic valve. And here just again is another example of a right dominant AV canal. Again, I would say this patient has got so little across the valve and so little left ventricle, it's going to land up being a one ventricle or 1.5 ventricle, however you plan on doing that. And here's the echocardiographic equivalent. So I say thank you to you for listening to me, and I'll be glad to answer any questions either from the floor or from the group here in Taormina.
It's not from the chat. You have the question and the question.
Stop sharing.
No, stop sharing. No, open the chat.
Okay. Yeah.
Yes.
Chat, there are 12 people that want to say something.
Se qualcuno vuole fare qualche domanda, Paolo, intanto un po' di riassunto.
I hope you got to see the video. That's how it started off early on. Slide is not visible.
But
a quick question. In summary, The last point was about the neural leaflet of the aortic valve.
I'm sorry, of the left AV valve.
Okay.
Sorry. Yeah, I made a mistake. Yeah. Smaller than normal mural leaflet of the left AV valve, not the mitral valve, so or the aortic valve. Yeah, I mistyped it. I'm sorry.
Inception of the cleft of the septum is the canal is not the obstruction.
So what was the question?
The insertion of the cleft
Yes.
is a normal insertion of the cleft of the septum.
Yes, always. I mean, I think, look, there have been occasional ones that are described as not, but I think, in my experience, it's 100%. Now, I mean, I've had only a certain amount of experience. I'm soon going to find a cleft that doesn't have. But, you know, clefts are very interesting because I think they are part of an AV canal that just hasn't fused. The last part hasn't normalized to be a mitral valve. And clefts exist in the posterior leaflet as well, in the normal. And if you look at some normal pictures of the left of the mural leaflet, you will see that there are tendinous cords on both sides going to the septum. So when you see those commissural scallops that the adults normally look at when they're looking at mitral valves, there's often tendinous cords to the back of the wall. I've got pictures that if you want to see them desperately, I can show them to you, but it takes a long time to pull them up. But that's always the case in the normal part. And I think that the tendinous cords tell you where they are. See, because the tendinous cords, or cordae tendinii, as the Latin like to describe it, that's Bob Anderson's thing, you know, and if I don't do it, he'll write to me telling me that. So the point is that what he said about this is that papillary muscles and cordae tendinae do not support the valve leaflets. They support commissures. And so the isolated cleft is not a cleft, it's really a commissure. And even on the back leaflets, the isolated cleft is a commissure. So did nobody get to see these slides?
One of the most important messages.
Differences there is not in the cleft there is no insertion of the
When you follow them, even if it's not in an AV canal, like in double inlet left ventricle, if you follow the clefts, the cordae tendinae, it's usually an AV valve, a semilunar valve situated in between the two, either the aortic or the pulmonary valve.
What determines the ventricular size? Like we
What determines it?
balance
Nature. Nature.
with regard
Because
to
it can be very big and it can be very small. I've seen complete AV canals, particularly in Down syndrome. In Down syndrome, seem to have a more benign AV canal defect than the non-Down syndrome. You know, 65 to 70% of AV canals are done in Down syndrome. So when Norm Shumway was doing surgery before he became a heart transplant, the only surgeons, the patients that Kabodi would let him operate on were patients with Down syndrome. So he never turned them down, and then he had to go and work on something. So he started working on heart transplants. So they call Kabodi the father of heart transplantation, because he made Shumway work on heart transplants.
I want to know, for you, which is the most important sign, anatomic feature that can make you on the way of LV obstruction, which is, if you make a list, you see the position of the papillary muscle, additional tissue, the shortness of the outflow tract, which is.
I think they're all important, but I mean, if you're asking me as an echocardiographer, I would look in parasternal long axis or subcostal or apical views of the outflow tract. to see that. And then, of course, you've got color flow that you put on there, which will show acceleration in that area. So, I mean, I don't know that any one sign is the most important. And I can't work on an ultrasound report by just looking at one thing. I must build up a total picture in order to say it. So I don't know how to answer that question, that what's the most important. But they all contribute to the left ventricular outflow tract being narrow. Dr. Bob Freedom wrote a paper many years ago about the sudden acceleration of subaortic stenosis in AV septal defects.
And the distance between the aorta and the mitral annulus.
Yes. Right. And the length, of course, it's
I
elongated.
think that is for
Right.
us, when we correct AV canal, if you see the aortic valve close to the VSD, you are safe.
Okay, right, yes.
If you don't, the valve is far,
Yeah.
then you can have
That's
risk.
And that, of course, is, I mean, as I look at embryology and I look at the new Anderson pictures and the sliding things, all of these things are not a single entity, but are part of a spectrum of what you see. So the aorta is coming from the right ventricle, far away, and there's a spiral in the septum that swivels it back, and then it has to sink through the interventricular foramen, which is now because the AV canal is also crossing there, and it's got to get and bang up against the mitral valve. That's why there's mitral aortic continuity. But the spectrum is from double outlet right ventricle to a normal heart with the mitral aortic fibrous continuity. And that's the same for all embryology. I mean, when you look at what we see embryologically, it doesn't just simply explain the defect, but it just shows you where you are on that spectrum of things that happen.
Deal. There's our okay. He is one of our cardiology. The point is probably
He came to my lecture in Agrigento. Right, that was good. Yeah.
So the point is, I think we have to use more 3D and 4D images.
Absolutely.
Intra-open.
And I tell you, see, that one thing about this condition with AV canal defects is what you can't see with MRI or CT is tendinous cords or mitral valves and tricuspid valve. You see them sometimes, but not well. The place where you see them is with echocardiography. And so a 3D echo is very important in this condition. And if you want to look at AV valve regurg to see where the leak is occurring, I mean, Lily Lim showed a whole lot of pictures at a recent meeting that I was at, where she showed the leak, where it came from, where it was, whether there was tendinous cord elongation. Sometimes the surgeon has to go in and put in a cortex cord to prevent the valve leaflet from prolapsing. And so there's a lot of stuff that you can learn from 3D that you can't see from any other technique. Are you using Philips or GE here?
Philips.
That's clever. I always knew the Italians were smart.
What do you prefer?
I prefer the Philips. Yeah, because the 3D is better. The things you can't do, you can still do them now, strain and strain rates. And you can do that with the Philips now. The new Epic. Are you using Epic?
Yes.
Epic, yeah. Okay.
So we stopped 1 moment for, or we go?
No, I think we need to stop and let's resend this to see that we can get the video working.
Okay. No, the video, no. When you stop and restart. But now if you share, go to PowerPoint and share the start to share.
Well, let me just put this out.
Yes, don't worry. This was the last part of the presentation.
Yeah, so I could close this.
Yes, close this.
First of all, I should go and find that thing on aortic valve. I have to find it now. I can't find it. All right, I'll just close it.
Yes, we got website. Stop.
Okay, now,
Yeah, go to the next.
okay. And everybody can see it. I don't have to worry.
You have to share.
Yeah, yeah.
Okay, yes, share screen.
Or on Zoom.
Yes. I think we are already open Zoom. This one, go to this black. Open this, open the arrow. Okay, now share. Okay, I
Okay.
think is this,
All right.
share. Okay,
Yeah,
you can go to the first
yeah.
and start.
Okay.
Okay, share.
So we've looked at some of the heart, especially the AV valves, and I'll kind of continue that theme. This is now, we're going to talk about Epstein's malformation and tricuspid dysplasia, just a few words about tricuspid dysplasia, because Epstein's malformation is a form of tricuspid dysplasia. It's that and many more things.
Yes.
Okay, so this is Willem Epstein. He lived in the last century. He was professor of medicine at Göttingen. He was born in Jauer in Prussia, educated in Breslau and Berlin, and appointed physician in Breslau and professor of medicine in Göttingen in 1874. And he died in 1912 in Göttingen. There is no information in Göttingen about him because the Nazi government destroyed all of the information on him because he was Jewish. Okay. And he looked at a young man, a 19-year-old bricklayer, whose name was Joseph Presser. Pressure, as they say. Pressure is not pressure, but pressure. Okay, if you can tell the difference. And Joseph was a bricklayer, and he came into his unit on a day with breath, shortness of breath, palpitations, cyanosis, and cardiomegaly, and was noted to have a cardiac murmur. That's about the same as we would get today from our medical students. And he died in 1864 between June the 28th and July the 6th. So he lived, 9 days. And Epstein had been trained by Rokitansky. Rokitansky was a pathologist in those age of great eminence. And Epstein was a Renaissance man. So he was able to do an autopsy. And he did these beautiful dissections, but there was no Kodak moment and there was no iPhones. So he had to call an etcher. An etcher drew these drawings that is in the Mayo Clinic now, I think. And they describe Epstein's malformation absolutely perfectly. Here's the deviated outlet septum. I beg your pardon, what am I talking about? There's the oval fossa. There's the coronary sinus. There's the increased right atrial size. There's the septal leaflet of the tricuspid valve. Here's the anterior leaflet and the inferior leaflet, and you can see that they fuse together. Okay, and this is the area of the atrialized right ventricle over here. And that's Epstein's malformation in a nutshell. And also he went back and looked at the outflow tract, and he turned the heart over and he looked at the valve from the other side. And this is interesting because this is not a view that surgeons get to see. This is a view only for morphologists and echocardiographers. And here you can see the tricuspid nature of this valve. But this valve is abnormal in its attachments. That's not like a normal tricuspid valve is attached. Okay? And the valve leaflets are fused together. So this is the problem with this defect. And this thing, this whole annulus is displaced into the right ventricular outflow tract, which you cannot see on the specimen. So in essence, this is a summary of what Ebstein's is. It's a rotational displacement of the tricuspid valve from the atrioventricular junction so that the right atrium becomes atrialized. The displacement occurs in a spiral so that the anterior superior tricuspid valve is attached normally. That's where the rotation occurs, with maximal displacement occurring at the junction of the inferior and septal leaflets. The tricuspid valve leaflets are abnormal, and the septal and mural leaflets, particularly the anterior superior leaflet, attached to the underlying myocardium. Okay. The distal attachment is also to the underlying myocardium and varies from normal to a linear or complete detachment of the leaflets. Because of the repositioning of the valve from this position in the annulus, like this, the tricuspid regurgitation is directed inferiorly. So you can tell where the valve plane is by seeing tricuspid regurg. And my feature for talking about it like this is I think that we've just turned the corner in Ebstein's malformation. And the reason for the turning is the work that's been done by Dr. De Silva, Jose, what's his other name? Paula?
Luciana.
Luciano.
Luciana da Silva.
Luciana is his wife.
Yes.
Luciana and the Silvas. Okay.
Jose Pedro da Silva.
Yeah. From Brazil. And this is a paper from which I'm an author on, from Freud, Lindsay Freud, in Circulation, that looks at 243 patients with Ebstein's anomaly or tricuspid valve dysplasia. And their follow-ups, long-term follow-ups, 5%, termination, 6%, fetal demise in 17%, live-born, of whom neonatal death occurred in 32%, leaving a neonatal survival of only 67%. That's before any surgery is done in the modern area. This leaves a 45% perinatal mortality. So we're dealing with a lesion that has got a very high mortality. And of course, if you look at this outcomes by gestational age and birth weight, the younger the gestational age and the lighter the birth weight, the higher the mortality. What about surgery? Well, all forms of surgery have success and failures, except the right ventricular exclusion, which has 100% survival or 0% mortality. And that is the procedure is known by the name of the Stans procedure. Vaughan Stans was at Stanford when he described this. And he described 5 patients who never had a mortality. And that was a real, they were all serious Ebstein's malformation that were likely to die. And so he published that, and that's become very popular. So the palliated varieties of ones that have done better. So what does an Ebstein's valve look like when you look at it? So on the left, I've opened a normal heart for you to show the inferior leaflet, the septal leaflet, and the anterior superior leaflet. And you see the papillary muscles here support the commissures of the valve and not the valve leaflets themselves. So one set of papillary muscles support 2 leaflets. Here, one set of papillary muscles support 2 leaflets, and so on and so forth. And there's no annulus of the tricuspid valve. There's an AV junction, but there's no fibrous tissue annulus on the tricuspid valve. So I've just drawn this as the AV junction here for you. And here you see the attachment of the tricuspid valve. And this is a mild Ebstein's. And you see, as we lose the anterior superior leaflet, we start talking to the mural and inferior leaflet. The valve leaflet gets displaced from the annulus in a progressive direction till the inferior leaflet is most displaced. Here we're looking at the right ventricle from the right side. Here's the normal we saw this in the AV canal. It's the same picture, but there's a tricuspid valve. And here's the medial papillary muscle, or the muscle of Lancisi, the anterior papillary muscle, and between that is the anterior superior leaflet, the inferior leaflet and the posterior papillary muscles on this side, and the septal leaflet attached also to the medial papillary muscle and the septum itself. And when you see this valve and you see an Epstein's malformation, this is a fairly typical look at what is called the keyhole orifice, which was described by Gordon Danielson as a feature. And you see here the valve is attached to the underlying septum. The papillary muscles are distorted, and there is what they call a hyphenated attachment of these papillary muscles. And my whole philosophy on Epstein's malformation has changed because I went to visit Dr. De Silva.
Yes.
And to see what he does, I had to realize that what I need to do is to be able to tell the surgeon everything that he needs to know and see before he or she does the surgery. So that's what the key of this presentation will be about. So here's a normal look at a normal tricuspid valve. Here's the papillary, the pectinate muscles. There's the coronary sinus. Here's the septal leaflet, the anterior superior, and the inferior. Now, the adult cardiologists call this the posterior leaflet. Can you see that the posterior leaflet is really the septal leaflet? Okay, but that's their confusion. And when you compare this to this, you can see here the green line is the attachment. This is the atrioventricular junction here. Here's the green line attached to the septal and the inferior leaflets, which come back round there, and when it's closed off, it attaches there. So this is the area of displacement of the valve leading to this area between the red dots and the green dots as the atrialized right ventricle. Okay, we'll see many pictures of this. So if this picture confuses you, you can go back and look at it later. But that's from Diane Spicer, so I'm sure it's absolutely excellent. Okay, atrialized right ventricle. See the valve leaflet there? Should be there. And what we need to do with the surgery is detach this damn thing, rotate it round, and attach it to the annulus, making sure that we don't get the coronary arteries underneath it.
Yes.
That's why I'm not a surgeon. All right. So what does it look like from the outlet? Here's a normal right ventricular outlet. Aortopulmonary trunk. Here's the septomarginal trabeculation, or what Dr. Van Praag calls the crista supraventricularis, with the parietal and the septal band, or the ventricular infundibular fold, and the septomarginal trabeculation, if you're like me, an Andersonian. And here's the moderator band, and here's the anterior papillary muscle, and there's the medial papillary muscle supporting the anterior leaflet, and on the back there you see the inferior leaflet and the mural leaf and the septal leaflet. And then on the back you see an Epstein's looking at it. And this is again another example, just like that picture that I showed you that Epstein drew on the outside. There's the main orifice. The secondary orifice is related to the tendinous cords being attached here. And here is the RV outflow tract. This is the septal, the parietal band of the crista, or the ventricular infundibular fold. Okay? And you can see here this valve leaflet is fused. The valves, the septal anterior leaflet and the septal leaflet are fused one to the other. Okay? And they need to be broken down, and tendinous cords need to be artificially made in here. And if we can tell the surgeon this is a wonderful thing for them to see. You know, I once went to a surgeon and we said to him, how's this information he gives us? He says, you give us all this wonderful information, and all we have to do is fix the patients. So we got to learn our basic. So here is a patient of mine, a boy of about 8 years of age, who died because my colleagues believed that he had a right to left atrial shunt, that if we closed the right to left atrial shunt, in an Epstein's, we would decrease the right to left shunting. He would not be so blue and he would grow. So Dr. Paul Ebert put in a patch in his atrial septum and he went back to the intensive care unit and he died. Because what this unit was doing, it was his pop-off valve, as we do with many patients that we do surgery on. So here we look at this poor Jamin who didn't get anything done on his valve here. Here's the anterior superior leaflet, and the green is the attachment to the AV junction. The AV junction is the red dots. And so here you see the anterior superior leaflet, which is normally attached, and then the valve rotated around like this to a variable degree, depending on the degree of Epstein's malformation. And here's the septal leaflet. And over here, there's minimal attachment. And over here, there's maximal attachment. So if you're going to do echocardiography, you have to look back here to see the maximal displacement. I'll show you that later as well. And then here, the valve leaflet is displaced from the valve and adherent to the underlying ventricular myocardium, and then comes back towards to fill the spiral. Now, a great forward stuff was done by Christian Schreiber, a surgeon who passed away, unfortunately, and looked at 27 cases of Epstein's malformation at the position of the AV valve in the Epstein's related to the position that you see here in the normal heart. And I've done this for the echocardiogram. So here, this yellowgram is the echocardiogram coming from below and subtending out there. So this is what you see on the echo. You see the normal atrioventricular junction in red there. You see the AV valve annulus attachments in green. And you see the valve leaflets and the tricuspid regurgitation coming in this direction, as I'll show you when we look at the movie. So here we look at that. And you see where the jet is going to? The jet is coming down to the diaphragmatic surface. Normally, tricuspid regurg goes in this direction. So if you see this here, you know the plane of the valve has been rotated around from its normal position to a position somewhere over here like this, making it that. And I think that this is a beautiful example of subcostal imaging showing everything that you need to know about Epstein's malformation. So you can see this point over here. What we don't see over here is the IVC, the inferior vena cava or inferior caval vein is here. This then becomes the atrialized right ventricle. And then this is where the valve is. And you can't see the septal leaflet because it's in the same plane as your picture. And you see the anterior superior and inferior leaflets of the valve. You see the outflow tract. You see the size of the functional right ventricle, which is small. And you see the pulmonary artery here. And if you look carefully, you'll see there's also an arterial duct there. Distal there, you see it's filling up in diastole. So this patient is surviving on its duct. Okay, so that's, I think we'll get to see that again. But once again, we look at embryology, and embryology tells us everything about Epstein's malformation. So this is at 23 weeks of Carnegie stage, which is about 8 weeks of gestation. It marks the end of the embryonic period and the beginning of the fetal period. Okay. So we know that the heart isn't perfectly developed in the fetal period. It also goes on developing in the embryonic period. It starts to continue to develop in the fetal period. And so here, what can we see at 8 weeks? In a normal fetus, you see the aortic valve, you see the right atrium and right ventricle, you see the septal leaflet, you see the anterior superior leaflet, you see the spongy nature of the right ventricular myocardium, and perhaps you also see a little bit of the inferior leaflet. This is from Wout Lammers and Jill Hickspoors, who have a series of wonderful pictures on embryology of the heart, where they've taken this and drawn these things. Each one of these is color-coded. So the yellow is the AV junction. This is the anterior superior leaflet. This is the septal leaflet. This is the muscular septum. This is the RV outflow tract, which you can't see. And here's the pulmonary valve. But the point that I'm making about this is at the end of the embryonic period, where the heart is essentially normal, the AV valves have not developed. Not in AV canal defects, where it continues to develop, and not in Epstein's malformation either. And so I just show you that even at the end of the embryonic period, there's still room for development that occurs. And this is my index patient. It says 19 weeks of gestation. And this is the first patient that I actually looked at with Epstein's malformation. And this patient has already established a displacement of the tricuspid valve from the mitral valve. Tremendous right atrial enlargement, a sort of abnormal right ventricle as well, and has already developed at 19 weeks tricuspid regurgitation. So between 12 weeks and 19 weeks, which is actually pretty young, there's still continuing development in terms of Epstein's malformation. And I think the story of Epstein's is an interesting one because it's a story where not only is there anatomical information going on, but pathophysiology changes and determines what happens to the valves and the function of the heart. And I think that's terribly important to think of as a concept. Okay, so I just expanded that in case you're looking at this on an iPhone. Okay, so I could say there's good going tricuspid regurg. The valve is already displaced. The right side of the heart is large. And the atrialized right ventricle is about 70% of the rest of the heart. And so we did this index in 1989, and we said, if you take the atrialized right ventricle and the right atrium, and you take the rest of the heart and you planimeter, when this becomes about 1-to-1, the prognosis goes down. And Dr. Sellermeyer and his colleague, Dr. Josephson, called me up and said, we'd like to explore this further. And they made a ratio of this varying in degrees and found that the bigger the ratio, big surprise, the worse the prognosis. Okay, the surgeons have made monkeys of us because they can now fix these patients and get away with a lot of things that we weren't able to get away with before. And also we can do things like close the ductus, which physiologically helps in utero in this condition. So what we have here is the original picture from the 1989 picture, and then mild, moderate, and severe Epstein's malformation. So there is mild, and you can see already prolapse of the septal leaflet and the anterior leaflet. More severe displacement, worse prolapse, and this heart on the right, where there's actually no tricuspid valve, because it's rotated out of the four-chamber plane into the outflow tract, and we've missed it. I can't get rid of this, I'm so sorry. Okay, but we move it away anyway. So look at this tremendous atrial septal aneurysm, because all of the right atrial blood is going to the left atrium. This is not a good prognosis. Now, let me point out to you now, if you look at this ventricle here, this ventricle has got spongy myocardium in it. Okay. I'm going to show you this a little later. And if you look at the function of this ventricle, it's not functioning very well. And we saw this on this patient, and we listed the patient in utero for heart transplant. And we did, on the second day of life, we transplanted this kid, because you can't use one ventricle when both ventricles are not functioning well. So here we go, moderate and severe. And what's important about Epstein's is the degree of tricuspid regurg tells you everything. So here's mild Epstein's. Here's moderate Epstein's. Okay, and here's severe Epstein's, but there's no AV valve regurg because the valve leaflet's fused. Okay, that's a bad one. Okay, it's already had a right ventricular exclusion. Now, this is the other half of that 19-week, where we look at the chest wall, the spine. I'm doing this for the surgeons, and the neck here. Okay, and here's the right ventricular outflow tract. I beg your pardon. That's the right ventricular outflow tract there. The aorta here, and there's the ductus shunting backwards into the pulmonary artery. Okay, and if I turn this round to 90 degrees, there is again the same thing. There's the descending aorta, here's the duct, and there's the right pulmonary artery going around here. And there's tricuspid regurgitation and displacement of the tricuspid valve. So what happened to the pulmonary valve in this patient? Excuse me, it was rather unusual because the valve got held in the closed position and developed synestia and never grow and developed pulmonary atresia. So there's functional and real acquired pulmonary atresia. If you leave a joint in one position for a very long period of time and you don't exercise it, that joint develops synestia and arthrodesis. The same thing happens with the pulmonary valve. And here you can see the classical Epsteins. Here's the anterior superior leaflet. Here's the septal leaflet, which is mal-displaced, and a little bit of the inferior leaflet. So what normally happens is the pulmonary valve becomes insufficient. And then the circulation becomes crazy because it goes from the ductus through to the pulmonary artery, through the pulmonary valve into the right ventricle, through the tricuspid valve into the right atrium, and right to left shunting. We used to call this circle of death. We now call it the circular shunt. But the shunt blood flow is going in the wrong direction. Dr. Rudolph called it invertension as opposed to hypertension. But anyway, so now here's my take on what happens with tricuspid regurg. As I said, it's a combination of morphology, development, pathology, and physiology all in one. So what's the first thing that happens is when you get this and the right atrium and the right ventricle start to enlarge, you get increase in the venous pressure. And the fetus is not capable of dealing with increased venous pressure because the albumin is low in the fetus. And so the lymph flow is 50 times what it is in us. For example, your lymph flow is 5 ml per kilogram per hour. A fetus is 50 milligrams per kilogram per hour, 10 times the amount. So all you need to do is tip it a little bit and they start to get hydrops fetalis, which is the classical representation of fetal cardiac failure. So that's the first thing that develops. The right atrium dilates and the ventricle dilates. We saw that already at 19 weeks. There's decreased forward flow into the pulmonary artery by one means or another. And that makes the pulmonary valve develop imperfectly. And you saw 2 examples of what can happen. And then they develop pulmonary regurgitation usually that puts you in charge of the circular shunt. Let me just move this out of the way so we can see what's going on here. Okay, functional or real pulmonary atresia. The pulmonary artery fills retrograde. There's more right to left shunting. Poor left ventricular function because the left ventricle's got nothing to squeeze against. It's squeezing against the right atrium. So the ventricular interaction is abnormal. The valve, the ventricle becomes, you don't want to take the picture yet. Wait a minute. Okay. You don't, the ventricle is working over time and it develops development and fibrosis. This decreases the filling and compression and diastolic function, which decreases coronary and cerebral perfusion. And that's why there's such a high incidence of death. Now, if you want to take a picture, you can take a picture.
A moment for the beach.
Moment for the Kodak moment. Okay. So we use lots of views to define. I'm going to just skip through this chart quickly. We have to do every view to look at Epstein's malformation. And the things are surprising where you found them. This is a parasternal long axis. Now, in a normal parasternal long axis, you only see right ventricular outflow tract. But when you get right ventricular enlargement, the heart rotates around in the clockwise direction. So you can see much more. So here's the right AV junction. There's the septal leaflet. There's the inferior leaflet. And there's the anterior leaflet. And here you see inferior leaflet, the anterior leaflet, and the septal leaflet plastered against the septum. So that's useful because it lets you look at all three leaflets all at once. And you get to see how they're functioning. The valve leaflets over here don't look that bad. Now we can look at the short axis, which is exactly 90 degrees. We see here again the AV junction in red and the annular attachment in green. So this is the atrialized right ventricle. And here we look at this in short axis over here, like that. And we see the left ventricle is squished. Okay? How can you expect this ventricle to function normally when it's squished and looks like this? The eccentricity index is abnormal. Yeah. And of course, there's no function against this area because it's the atrium here. So we've got inferior leaflet, anterior superior leaflet, and septal leaflets all in one show. And so you have to scan up and down in order to see this. Okay, I'm taking the leaflets away there. Okay, inferior leaflet, anterior leaflet, there's the medial papillary muscle, septal leaflet, etc. Inferior, anterior, septal leaflet, all three leaflets. And you know the surgeon's going to take this and take the tendinous cords underneath this and take this away so that he can make the cone out of this lesion. Okay, that's where my understanding is. This is just a picture a little higher up where we see the pulmonary valve outflow tract. And this pulmonary valve shows you better the ductus shunt coming in here between the blue of the two branch pulmonary arteries and the blood flow going across the pulmonary valve into the right ventricle. So that's the circular shunt once again. So all seen in one frame. We look at this, and this is how to look at 3D. Don't look at 3D from above because you can't work out where to do the plane. Look at it from below and you can see this. So here again is in a 2D model. You see the anterior superior leaflet, the septal leaflet, and the inferior leaflet very beautifully. And you can see where the valve leaflet is attached here by major and minor tendinous cords. Again, thinking of this in a surgical way. Now, four-chamber view was described in 1977 by me in Epstein's malformation. And it changed the way people look at Epstein's disease. So here's a heart that's been cut in normal. And what Bob Anderson and I did is we sliced this heart in a four-chamber cut. So here's the echo of the four-chamber cut placed on the apex. We take that away. And now we see the anterior superior leaflet here with all of these chordae over here that the surgeon has to cut away as he's doing it. So we show you that, okay? You can see the anterior papillary muscle, not the moderator band, the anterior papillary muscle, okay? You see the septal leaflet is plastered against here, and you can also see the inferior leaflet, but you can't see it because it's on the septum, lying on the septum, plastered on the septum. So this here all is atrialized right ventricle. Now, Dr. Justin Tretter, who also is at a Congenital Heart Academy Fundi, comes over here and he sent me this picture. And I love this picture because it shows very clearly the tricuspid regurg. Look, it's not a great way of looking at it. It shows the origin here. It shows you this anterior papillary muscle coming up over here. So this is atrialized right ventricle, functional right ventricle, even going down here. There's the left ventricle and the left atrium. And look over here. He's got non-compaction or spongy myocardium here. And he didn't tell me that. I asked him, I phoned him up. I said, Justin, this patient's got spongy myocardium. He says, yes, I'm sorry, I forgot to tell you. So here's an echo showing exactly the same thing. So all of these three pictures will show you what you can get out of echocardiography. Here's a little bit of the TR. We may not be in the right place to see the jet, but I think you can see the chamber proportions are the same in all three specimens. And here's that single plane here with the MRI as it's made, showing the MRI diagram and echo with all three of the things together. So you've got AV junction, you've got attachment of the valve. AV junction, attachment of the valve. AV junction, attachment of the valve. And we've got tricuspid regurg, and we see the tricuspid regurg is perpendicular to the valve plane. So you know where the valve plane is from where the tricuspid regurg is coming. That's not terribly important for the surgeon, but he wants to know where the valve plane is. So that's where you see it. And again, I told you there's a little ductus going on here. Okay, so color shows you a lot of information. And this area here is all that plastered atrialized right ventricle that we saw on the septal surface. So that's inferior. Now we can turn the heart around and look again from above here, and we see the right atrium and the left atrium here, and we see the tricuspid valve over there. So the tricuspid valve usually comes from the inferior vena cava right there. There's the coronary sinus in it. So all of this is atrialized right ventricle. This is a huge atrialized right ventricle. And I'll show you as we look at it that this right ventricle is abnormal. It's thin and it's fibrotic. So one of my colleagues, the other guy on the paper on this book, says he doesn't believe it's dysplastic because he didn't see any real dysplastic myocardial cells, but they've been replaced by fibrous tissue. So there's fibrous replacement, which I call dysplasia. And I call it dysplasia because I need a D for Epstein's malformation. So here's the two. Here's the displacement in the 4-chamber view, and here's the displacement in the 2-chamber view. Okay, this is all of atrialized right ventricle, abnormal right ventricle. And here you can see at 90 degrees to each other, the tricuspid regurg going down towards the diaphragm. And I think this is the best summary of Epstein's malformation in a patient I've ever been able to show. Okay. And you see that the jet is not a cone. The jet is shaped like a squashed ice cream. So it's bigger in one plane and smaller in another plane. Yeah. So I say Epstein's, and this, don't take any pictures yet. Epstein's is the dozen D syndrome. So I like alliterations. In English, they have Ds. Okay. So the first is the displacement of the proximal attachment of the tricuspid. The valve itself is dysplastic too. 3, distal attachment abnormalities. We've seen that. 4 is dysplasia of the underlying myocardium. We've talked about that. And 5 is arrhythmias. And arrhythmias in Epstein's are a serious problem. They get more serious as we get older. But the WPW is easily explained because the normal annulus of the tricuspid valve is electrically insulating, but it's not insulating in Epstein's. And it's slow conduction down and fast up through the AV node. So it gives you orthodromal reciprocating tachycardia. And because it goes down in that direction, the QPR is shortened because the muscle is already activating down the area of the atrialized right ventricle. And of course, a ventricular fibrillation and other ventricular arrhythmias for other reasons, but certainly dysrhythmias are part of Epstein's malformation and cannot be ignored. And not only that, but if they're present surgically, I think the conventional wisdom is that you do an EP study today if you do that, because you may have to maze the patient. Does everybody know what a maze procedure is? All the surgeons do. What about the physicians? Do you know what a maze procedure is? Hello?
A maze.
It's an amazing procedure, the maze procedure.
Yes.
Yes, it's amazing. They cut the whole atrium off, made fibrous connections so that there's no conduction between the atrium and the ventricle. And so that's basically in the bottom line. Okay. Now, there's no D in tricuspid regurgitation, but there is in Doppler evidence. So there's the D there for Doppler evidence. Now, the dysfunction of both ventricles, both systolic and diastolic. If you do tissue Doppler and strain rate imaging, you will find that these ventricles are abnormal, even from fetal life onwards. The right-sided dilates and there is associations with the arterial duct or the ductus arteriosus. There's deformity of the right ventricular outflow tract and pulmonary valve, which we've seen. There are other defects like VSDs, Epstein's malformation, congenital transposition. And this is my number 12. Think De Silva operation. So when you look at this as an echocardiographer, the surgeons, you don't have to worry, they're going to look at it like that anyway. But there's, as an echocardiographer, to tell the surgeons what you think he needs, and also to talk to the surgeons to ask them, what do you want to know? I like to have the surgeon there when I'm doing the echo,
Yes.
so I can tell him. And then, of course, the last D is for all of us, death. And it's Baker's dozen is 13. Okay, so we can make this mild, moderate, and severe. There's the junction, there's the valve. Junction valve, more displacement, and the most displacement. And I put the Schreiber diagram in there to show you that we're looking at a variable degree of displacement. So that's apical. Now, I told you that when you look at the valve here, if you take an echo in the 4-chamber plane here, you don't get much displacement of the tricuspid valve. You have to come down to the back. So this is the same patient. This is an adult woman who got pregnant and who's got Epstein's malformation. Okay? All right? And here you see, there's the septal leaflet there. The anterior leaflet is attached to the papillary muscle there, like we've seen it there on the echo. Okay? And then if we scan backwards, the valve is much more distally displaced there. Let me take the labels off so that you can see that. See, the valve is attached there? And here, the valve is attached all the way down there. You can see the valve running on the septum there. So you have to go to the back if you want to do this displacement. And then you can get what the Mayo Clinic have described by Sinner et al. I don't think it's really that important. And we can do the same subcostally. So here's a subcostal valve where there's the annulus, there's the valve. The anterior superior bridging leaflet is beautiful, but the septal and the inferior leaflets are displaced. Here's the displacement between the inferior vena cava and the valve leaflet here. And so we've got mild, moderate, and severe. And I'll let you see that in real time. And this one is sort of like in the middle. I think this one is this kind of Epstein's. And you can see that these are not the same patient because the ECGs are entirely different. This one doesn't even have an ECG. But you see where the IVC is here? There's the IVC, inferior vena cava. So the valve leaflet is displaced, and we can tell exactly the displacement, and we can look at the underlying myocardium, which we will do in a few moments. And of course, valve dysplasia is a point. Here's a typical Epstein's with valve dysplasia of the septal leaflet and the anterior superior leaflet. You can see there's no nice tendinous cords over here. And this is a bunch of verrucae. And here is, there's not even a complete cardiac cycle. It's just systole. And this valve does not close. You know that, and you can see already that there's massive tricuspid regurgitation, even without looking at the echo. And there, of course, is put the valve leaflet on there. And you know that this is a neonate and it's going to go either for surgery or to death. So this is like a surgical immersion. Here again is the inferior leaflet dysplasia. This is the inferior leaflet here. Here's the inferior leaflet displaced here, and the anterior leaflet is also dysplastic. Here's the septal leaflet. Here, look at this. It doesn't really look like a leaflet. It looks like a little blob. I would be very disconcerted if I saw that there's a surgeon. That's why I'm not a surgeon. Okay, and you see there's the valve leaflet, which is herniating and prolapse. And this valve has got nothing to oppose to. So it also herniates and prolapse. So we would call this a moderate Epstein's, not a severe Epstein's yet. And here's another one with the echo. Here again, you see the septal leaflet becomes a series of verrucae. Look at this anterior leaflet. It's abnormal. Not only that, but you can see the basal chordae or the strut chordae going through the valve leaflet towards the base. We see a lot of strut chordae in our echo. We can record them. We get to the base, you can see the strut chordae very beautifully. And here again, you see all of the attachment that when you watch the surgery, clip, snip, snippy, scissor, what you're doing to this valve, he's taking it and rotating it around and making a cone and then re-establishing it in the AV junction. Okay, so here's the distal attachments. Look, this one's perfectly normal. We talked about this, but look at what happens here. This is tendinous cords from the apex. Look, there are many of them. We call this a hyphenated attachment. And then this goes even further over here where we've got linear attachments and hyphenated attachments. And here, this one is entirely linear. So I've put three things, they like milestones. It's a journey that goes from normal all the way through to total adherence of the valve leaflet to the underlying myocardium, or backwards. I assume it's backwards that this happens. You know, through a process of undermining of the valve muscle. So I'm sure that it goes this way in embryology, but it goes this way in terms of severity. Okay, so we saw this. Here's another one here showing the abnormal valve leaflets, which are still not opposing and associated with a lot of tricuspid regurgitation and a huge right ventricle. No septal leaflets seen there. We'll see septal leaflets in a minute. You have to look for them. Here's this abnormal septal leaflet. You see, there's the attachment. And this is all attached to the underlying myocardium. Dr. Agati is going to go in and liberate this free, make something to do with the tendinous cords, make the cone, and so on and so forth. So there's one, and there's the other one in a fetus. So this is postnatal, and this is a fetus that turns out to be like this one here. Yes. So we can see this, and I think the story starts fetally in this condition, and what's doing a lot good to it, make it better for us, is to understand fetal physiology and start treating these babies in utero. So here are inferior leaflet attachments. These have also got to be removed by the surgeon. Okay, so we look at this on the specimen here. See the anterior superior leaflet with the medial papillary muscle. And the leaflets become amorphous and are not clearly defined. Okay, yes, I understand. I'm sorry I was late. I'm really sorry you're going. Okay, all right. So this is tethering of the leaflets, and you see it very beautifully on the specimen. And you see it also on the echocardiogram. Okay, this is hyphenated attachments. You see the norm, look at this, all the way over there, all the way there, all the way there, all the way there, all the way there. All of these things have got to be liberated. And here you see it here. And by the way, there's spongy myocardium here too. So this is spongy myocardium with these attachments. Some more of attachments. Here there's linear attachment and hyphenated attachments. And I put this in to show the anterior leaflet attached through these structures there. Let me take the arrows away from you. Okay, and there you see all these multiple attachments. And then, of course, the valve may be totally adherent. Here's a valve that presents like tricuspid atresia. You see the valve, you see the ventricle underneath, it doesn't look so great. You see the valve moving backwards and forwards, but no blood coming across it. So that's almost like a Stone's procedure done. Here's a boy of 12 years old that I followed with tricuspid adherence to the underlying myocardium. He had a right to left atrial shunt. He had left ventricular shunt, and he had small muscular VSDs. So he was like divinely banded, yes. And he lived very, very easily until the surgeons got hold of him and tried to fix him. And he did very poorly. We had to reconvert him into a Glen after a Fontaine. Didn't work for him. But anyway, there you see the left to right shunt, but the atretic tricuspid valve. And then this is fibrosis. If you shine a light through normal muscle, it does not transilluminate, but fibrous tissue transilluminates. So this has a light, an iPhone in the right ventricle, and you see how this illuminates because it's all replacement fibrosis. And here is a right ventricle. I want you to look at this right ventricle here. Look how thin this right ventricle is. It's paper thin and abnormal. And this is part of what usually goes away in an annuloplasty. So when the surgeon sees this, he has to cobble this up. To plicate it is the correct word, not cobbled. And lastly, at the end, is this which you saw before. But what I didn't show you is this is an M-mode echocardiogram from 1982 in my laboratory, showing pulmonary valve opening, closing, opening, closing, opening, closing. Okay, normal pulmonary valve in this patient. Okay, at 36 weeks, this is what happened. No opening, no closure. And this is from 38 weeks. The fetus died in utero at 38 weeks, and we saw this. Maybe this would have been an opportunity for doing something on this valve in utero. Certainly, if you do that, you need to do something about the ductus, but we didn't have that sophistication in those days. So that's the story. So in conclusion then, these defects found with ASDs, VSDs, pulmonary stenosis and atresia, excessive trabeculations called spongy myocardium, Wolff-Parkinson-White, and congenitally corrected transposition. And this is an example of a morphologically right ventricle on the left side. There's the LAD, and there's the left ventricle on the right side. Here's the left ventricle, here's the right. And this disease, according to Dr. Anderson, we call Epsteinoid because there's no atrial thinning in this condition. So having said that, we would call this Epsteinoid. But the very next picture is from Diane Spicer's group, which shows the displacement with the atrial thinning of this condition in congenitally corrected transposition. So it's not always the case. The echo doesn't match it perfectly because I don't see displacement of this here. But I wanted to put this out to show the beautiful displacement between the septal and the anterior leaflet and the tricuspid. The De Silva procedure has not worked well in this group of patients, and I don't think they're done anymore. VSDs, here's a VSD in a normally related great vessel, and you see there's a left to right shunt at ventricular level underneath the displaced septal tricuspid valve. And here is a ventricular septal defect in congenitally corrected transposition going from the pressured right ventricle into the pulmonary left ventricle across a small, insignificant VSD. And here's spongy myocardium. I showed you this before. Here's an example of spongy myocardium in Epstein's malformation. This is this patient after birth. You see how hard it is. They look more like ground glass than they look like spongy myocardium. Look, here's the myocardium. And now we put some color flow on that. And you see the flow going in and out of the ventricle there. See that? All the way there. This is all non-compact myocardium. The compact myocardium is very thin, and it goes all the way in there. So this patient, the left ventricle was so bad, we decided in utero to list it, and the patient got a transplant on the second day. We can't actually do that anymore. Here's a better example of the spongy myocardium in this patient. We're not allowed to list patients anymore. Now, I want to finish with these two wonderful cases. This is the right ventricular exclusion or the stance procedure. Here's this Gore-Tex patch placed in the supratricuspid annular position to avoid the coronaries, with a little hole made to decompress the right ventricle. And I always show this picture after I show Dr. Stanz's 5 patients, because this picture is an autopsy. So not all patients with this condition survive. Okay, and this is what it looked like before. Look at the massive tricuspid regurg. Look at the size of the right ventricle compared to the left ventricle. And the patient undergoes a Stanz procedure. I got this from Elizabeth Langford from Dr. De Silva's laboratory. Here's the supraannular position of the patch, the little hole showing inflow and outflow, and the total reversal and the abnormal function, return of normal function following this procedure. And these patients can survive like this and may undergo eventually a De Silva procedure. He's done several of them. And here's an example of the De Silva procedure. Basically, you take the tissue off there and make a cone and put it back. You take it off here, cut the valve leaflet off all the way, cut all of these abnormal cords except for the big anterior papillary muscle, rotate it round, do an annuloplasty of that dead atrialized right ventricle, and sometimes put in an annuloplasty ring, especially in older patients. And I show this patient because this is a patient that had, this is actually Dr. Joe Delaney's pictures of the repaired position in the tricuspid annular position. And this is the change of that huge right ventricle to here, showing the cone-like procedure, normal ventricle, return of size of the atriums, and with just the slightest hair of tricuspid regurgitation. So I think that this is a wonderful, wonderful example of, and gives me hope for this condition, and allows me to focus my attention on doing this procedure. Now, as I said, Epstein's is a form of tricuspid dysplasia. The only difference between Epstein's and tricuspid dysplasia is tricuspid dysplasia can be an acquired lesion. But if it's a congenital, it will occur, and wherever it occurs in utero, it will have the same physiological and pathophysiological consequences. So let me just show you a normal vent. We saw this before. Here is the dysplastic valve. Here, the verrucous formation with the abnormal tendinous cords. Abnormal tendinous cords and this hyphenated attachment of the valve. So everything that you can see in Epstein's malformation, you will see in tricuspid dysplasia, but you don't see the displacement. And of course, surgical repair depends on what type of lesion you're dealing with. I didn't have enough time, but we've had many patients with tricuspid dysplasia that we've just fixed with annulus. Thank you.
Thank you.
Now, let's see if there's anybody that wants to say anything. Chat, there's 6 chats here. Hello from Algeria. There is no voice. I mean, I don't know what you can do with it. No video.
No, this was before. No, not now. Now it's okay. It was okay. This is 3:3 a.m.
Okay, so there's not 3 of these.
Don't worry, it was okay. It was only the last part of the. Oh.
Yeah, I could answer this person here.
There is people from Ethiopia.
Yeah, they said that their patients get pulmonary hypertension, which is true. AV valve disease gets pulmonary hypertension. That's why you have to repair them between 6 weeks and 3 months of age before they get pulmonary vascular disease. Once they got pulmonary vascular disease, you got a problem.
Okay, we have another presentation.
Okay, all right. Well, I thank you very much for listening to me. It's a great pleasure to be here. Thank you, Sasha, for having me. I'd like to spend more time here.
Yes. Don't say again. we will leave you here.
Okay, so I can disconnect here?
Yes.